Bismillahirrahmanirrahim. Assalamu alaikum, and welcome to the sixth session of HAEMCON 2021 on bone marrow transplantation, or which is better referred to as stem cell transplantation nowadays. So, just a brief introduction about myself. I'm Dr. Ghassan Umair Shamshad. I did my FCPS Hematology in 2012, and currently I'm working as the lead at Stem Cell Research Lab at National Institute of Blood and Marrow Transplant. So this session comprises of three free papers from our talented hematology residents and 3 talks from our esteemed international speakers. This would be followed by discussion and question answer session with our panelists, which comprises of our national experts in this field. I hope we have them online. We have Dr. Tahir Shamsi joining us from Karachi. Also joining us from Karachi is Dr. Salman Adil. And over here in this hall, we have with us Dr. Qamar Nisa Chaudhary. So without further ado, I would like to invite our first speaker, Dr. Noor Shamim. She is a resident clinical hematology at the National Institute of Blood and Marrow Transplant, and her topic of presentation is outcome of autologous stem cell transplantation. Dr. Noor Shamim.
Assalamu alaikum. I'm Dr. Noor Shamim, resident clinical hematology, Armed Forces Bone Marrow Transplant Center, and today the topic of my study is outcome of autologous stem cell transplant in patients with lymphoma. First, we will be discussing the 2016 WHO classification of mature lymphoid, histiocytic, and dendritic neoplasms, which are broadly classified into 5 major groups: mature B-cell neoplasms, mature T and NK neoplasms, Hodgkin's lymphoma, post-transplant lymphoproliferative disorders, histiocytic and dendritic cell neoplasms. Autostem cell transplants is usually done in patients with refractory relapse Hodgkin lymphoma and DLBCL, in cases of relapsed Burkitt lymphoma, and as first line in mantle cell lymphoma and anaplastic large cell lymphoma. The objective of the presentation and the study is to determine the outcome of autostem cell transplant in patients with lymphoma. The study design was cross-sectional observational study, which was conducted in Armed Forces Bone Marrow Transplant Center. The duration of the study was from January 2010 to April 2020. The study population consisted of 23 registered cases. The inclusion criteria included all patients who were newly diagnosed, relapsed, refractory of both genders undergoing autostem cell transplant for lymphoma. The data collected included age, gender of the patients, baseline counts and chemistry, type of lymphoma, comorbidities, type of induction therapy given, and response to therapy. Coming to the results, amongst 23 patients, 83% were males and 17% were females, and the median age was 39 years. 70% of the patients included non-Hodgkin's lymphoma and 30% included Hodgkin's lymphoma. The number of cases included 7 cases of Hodgkin's lymphoma, 7 of diffuse large B-cell lymphoma, 3 cases of mantle cell lymphoma, 2 cases of anaplastic large cell lymphoma, 2 cases of Burkitt's lymphoma, 1 case of T-cell large B-cell lymphoma, and 1 case of small lymphocytic lymphoma. The pre-transplant disease assessment included 5 patients in CR1 and 18 patients in CR2. The mobilization protocol was given in 95%, it was cyclophosphamide and GCSF, and in 5% of the patients, it was G-Plerixafor. In 95% of the patients, the conditioning regime given was BEAM, and in 5%, it was Benda plus AIM. The median CD34 dose was 3.87, and the median TNC dose was 3.5. Neutrophil engraftment occurred at a median of 11 days, and platelet engraftment occurred at a median of 20 days. Complications post-transplant included febrile neutropenia in 78% of the patients, mucositis in 56% of the patients, gut toxicity in 52% of the patients, renal impairment in 26%, and respiratory tract infections in 39%. Conclusion is at a median of follow-up of 37 months, the overall survival was 91%, the disease-free survival was 76%, and the treatment-related mortality was 8%. In 23 patients, 2 of the patients expired due to treatment-related complications, and 5 of the patients relapsed. According to international data, in the year 2015, a study was conducted that included 122 patients, and their overall survival was 50% with a median follow-up of 2.5 years. Another study conducted in the year 2011 included 157 patients, and their overall survival was 84% with a median follow-up of 2 years. Thank you very much.
Right. Thank you, Dr. Noor, for that brief and crisp presentation on your data regarding autologous stem cell transplantation. So our next speaker is Dr. Ayesha Iftikhar. She is a senior resident of clinical hematology at NIBMT, Rawalpindi, and she will be sharing the experience from a tertiary care hospital in Pakistan regarding acute graft versus host disease after allogenic hematopoietic stem cell transplant. Dr. Ayesha.
Okay, Assalamu alaikum. I'm Dr. Ayesha Iftikhar, resident clinical hematology from Forces Bone Marrow Transplant Center. The topic of my research is acute graft versus host disease after allogenic hematopoietic stem cell transplant experience from a tertiary care hospital in Pakistan. There are no conflict of interest to declare. So diverse risk factors for acute GVHD have been described over the last 3 decades, all of which adversely affect the outcomes of any allogenic transplant. Standard treatment of acute GVHD consists of corticosteroid or first-line treatment therapy. So the primary objective of my study was to determine the frequency of acute GVHD in patients undergoing transplant for various hematological disorders. And secondary objective was to analyze the risk factors, treatment response, and transplant outcome in patients with acute GVHD. So it's basically a retrospective cross-sectional study carried between January 2016 till December 2019 at Armed Forces Bone Marrow Transplant Center. Inclusion criteria included all the patients who underwent transplant for various hematological disorders of both genders and all age groups. Exclusion criteria included patients who had a primary graft failure and the patients who underwent second allogenic transplant. So assessment of acute GVHD was done on the basis of history, clinical exam, biopsy, and Seattle criteria. And acute GVHD was defined as GVHD occurring within the first 100 days after transplant. Following risk factors were considered for analysis, which included donor age, donor patient gender mismatch, donor type, donor parity, source of stem cell, conditioning regimen, underlying disease, GVHD prophylaxis, CD34 and TNC dose, number of blood transfusions, ABO incompatibility, and time of onset of acute GVHD. Evaluation of response of therapy was done retrospectively. It was retrospectively assessed for response to first-line treatment therapy, which included prednisolone, or topical steroids 7 days after the initiation of therapy. Response was defined as a complete resolution of all manifestation of acute GVHD or a decrease in organ stage by 1, and progressive disease was defined as an increase in organ stage by 1 or no improvement from initial stage of acute GVHD. So total 198 patients were evaluated, and the median age of patients was 10 years. 68% were male and 32% were female. So patients underwent transplant for various hematological disorders. The most common was aplastic anemia, followed by beta thalassemia major. So frequency of acute GVHD was 21%, in which the clinical significant GVHD developed only in 14%, that is of grade 2 to 4 GVHD. So among the 42 patients who developed acute GVHD, the most common organ involved was skin, followed by gut 34%, and in liver 7%. And symptoms of acute GVHD started at a median day of day 22 post-stem cell transplant. So we broadly categorized the patient into 4 subgroups. And the frequency of acute GVHD was observed highest in the malignancy group to be 34%, followed by immunodeficiency syndrome in which the GVHD was 31%, and then beta thalassemia 25%, and the lowest incidence of acute GVHD was observed in the bone marrow failure group. So as per the Kaplan-Meier survival curve, the overall survival at a median follow-up of 20 months was 79.4%. With GVHD, it was 76.2%, and without acute GVHD, it was 80.3%. Overall survival in the subsequent groups, beta thalassemia with GVHD, it was 62.5%. Without GVHD, it was 75.9%. In bone marrow failure group, overall survival with acute GVHD was 75%, and without acute GVHD, it was 72.9%. In malignancies, survival with acute GVHD was 66.7%, while without GVHD, it was 83.5%. In immunodeficiency group, with GVHD, the survival was 85.7%, while without GVHD, it was 61.5%. So the risk factors which were evaluated, first the GVHD prophylaxis. In the beta thalassemia group, all the patients received CSA and methotrexate for GVHD prophylaxis, and among them, 25% developed acute GVHD. In the bone marrow failure group, which included 79 patients, the most common regime for GVAD prophylaxis was CSA, in which only 8% patients developed GVAD. The 4 patients who underwent haploidentical transplant received CSA, MMF, and PT-Psi for GVAD prophylaxis. In that group, 25% GVAD was observed. In malignancy group, the most common regime for GVAD prophylaxis was CSA plus methotrexate, and among that group, 30% developed acute GVAD. In immunodeficiency syndrome, the most common regime for GVAD prophylaxis was CSA plus MMF, and among that, 50% patients developed acute GVAD. Other risk factors that were evaluated were donor parity. So among patients who underwent transplant from multiparous donor, 50% patients developed acute GVAD compared to non-parous donor, in which the GVAD was only 18.8%. And this result was statistically significant with p-value of 0.01. Same in the conditioning regimen, significant acute GVAD was observed in the MAC group compared to the non-myeloablative group, in which the GVAD was only 7.5% compared to the MAC group, in which GVAD was 25.7%, and in RIC group, 34.6%. Most of the patients in the non-myeloablative group were of aplastic anemia. And this result was also statistically significant with a p-value of 0.003. So other risk factors were also evaluated, but they were not statistically significant, included the source of stem cell, HLA compatibility, presence of ATG in the protocols, median CD34 count, mean TNC dose, median donor age, less than 30 and more than 30 group, ABO mismatch, prior blood transfusions, patient-donor gender mismatch. So these, all the risk factors were not statistically significant. So the response to first-line treatment therapy in grade 2-4 acute GVAD patients, which were 27, 73% were steroid responsive, while 27% were steroid refractory. Among the 7 patients who were steroid refractory, 5 patients received mesenchymal stem cell plus infliximab as a second-line therapy. 1 patient received only infliximab, and 1 patient received mesenchymal stem cell. Among the 7 patients, 3 patients expired later due to extensive gut and liver GVAD. So the overall survival of acute GVAD patient at a median follow-up of 20 months was 76% were alive, while 24% died. Among the 10 patients who died, 3 died of acute GVAD, 2 patients developed hemorrhagic cystitis, 2 patients developed graft failure, and 3 patients later died at home due to unknown reason. So the complication in acute GVAD patient, 10 patients later on went on later to develop chronic GVAD, 3 patients developed graft failure, 1 patient developed PRES, 1 patient developed autoimmune hemolytic anemia, while 26 patients developed no complications. So in literature review, a study published from Pakistan in 2016 showed an incidence of acute GVAD was 45.7% in post-allogenic beta thalassemia patients. Another study published in June 2013 from Pakistan showed a cumulative incidence of acute GVAD to be 34% in post-transplant patients. A study from America, which was published in 2012, showed a cumulative incidence of grade 2 to 4 acute GVAD to be 39% in post-transplant patients. And a study published in January 2011 from USA showed that 50% acute GVAD patients responded to steroid, and non-responders had a mortality rate of 95%. So ladies and gentlemen, concluding my study, the incidence of acute GVAD in this study was lower as compared to the international literature. Overall frequency was 21%, and clinical significant acute GVAD developed only in 14%. The reason of which could be decreased HLA disparity among our patients due to intermarriages, use of bone marrow as a primary source of stem cells, and use of ATG in most of our protocols. GVAD developed mainly in patients receiving stem cell from multiparous donors and those who received RIC-MAC conditioning regimen. Highest incidence of acute GVAD was observed in the malignancies group, while the lowest incidence was observed in bone marrow failure group. Response to first-line treatment therapy was observed in 73% patients, while in the steroid non-responder group, 43% mortality was observed. There was no significant difference in overall survival of patients with or without acute GVAD in all the groups. Thank you.
Thank you, Dr. Ayesha Iftikhar, for your very comprehensive data on acute GVHD. It was quite fascinating to see that donor parity is one of the major causes of acute GVHD, and it's seen mainly in the malignant disorders. So our next or the last free paper is by Dr. Mussawir Hussain. He is also a senior clinical hematology resident at NIBMT Rawalpindi. The topic of his presentation is outcome of hematopoietic stem cell transplantation in Fanconi anemia using radiation-free regimen, a single center experience from Pakistan. Dr. Hussain.
Assalamu alaikum. I am Dr. Mussawir Hussain, resident clinical hematology at AFBMTC. Today, I am going to share our center experience of hematopoietic stem cell transplantation in patient of Fanconi anemia. Fanconi anemia is an autosomal recessive and rarely X-linked inherited disorder characterized by congenital anomalies, progressive bone marrow failure, and predisposition to develop malignancies. The clinical manifestation of Fanconi anemia are heterogeneous. Majority of the patient population having skeletal abnormalities. However, 30% of the patient have no abnormalities. Management of Fanconi anemia include regular monitoring for bone marrow failure and malignancy, supportive care, that's treatment for anemia, infections and bleeding, and specific treatment including anabolic steroids and hematopoietic stem cell transplantation. Anabolic steroids such as danazol and oxymetholone had developed a transient hematological response in 50 to 70% of the patient. However, this response is transient and the patient may develop complications such as pileosis hepatis and benign and malignant hepatic neoplasms. The only curative treatment option for Fanconi anemia is hematopoietic stem cell transplantation. Now, I am going to present my own data of patient of Fanconi anemia in hematopoietic stem cell transplantation in terms of overall survival, acute and long-term transplant complications. It is a retrospective cross-sectional study conducted at AFBMTC from January 2008 to December 2020. Both indoor patient and outpatient medical record were included in the study. The inclusion criteria of my study was those patients having age 18 years or less, any gender, and confirmed diagnosis of Fanconi anemia. Those patients who were previously diagnosed Fanconi anemia and transformed into MDS and leukemia were excluded from the study. Among 27 patients, 19 were male and 8 were female. Median age at diagnosis was 8 years. Median age at transplant was 10 years. Among the patients, majority of them were between 6 to 10 years. All the patients were in a plastic phase and 25 patients having congenital anomalies. However, 2 patients having no Fanconi features. 26 patients received matched donor sibling transplant. However, 1 patient received matched parent transplant. 18 patients received no ABO mismatch transplant. However, 5 patients having major ABO mismatch transplant and 4 patients received minor ABO mismatch transplant. 17 patients have no gender mismatch transplant and 10 patients receive mismatch transplant. Conditioning protocol, 23 patients were given conditioning protocol of fludarabine 120, Cy30 and ATG20, and 4 patients were given fludarabine 150, Cy30 and ATG20. 20 patients were given BMH as a source of stem cells, and 5 patients were given BMH and PBSC as a source of stem cells, and 2 patients were given PBSC only as a source of stem cells. Median CD34 dose was 5.8 and median TNC dose was 5.1. For GVHD prophylaxis, 20 patients were given only CSA, cyclosporine, and 4 patients were given cyclosporine and MMF, and 3 patients were given cyclosporine and methotrexate per GVHD prophylaxis. Majority of the patient achieved neutrophil engraftment on day plus 11 and platelet engraftment on 20 and day plus 20. 23 patients developed CSA-induced hypertension and 22 patients had neutropenic fever, while 16 patients had mucositis, among which 9 patients developed grade 3 to grade 4 mucositis, 6 patients having grade 2 mucositis, and 1 patient having only grade 1 mucositis. 6 patients having CMV reactivation, and 2 patients developed hemorrhagic cystitis, and 1 patient had VOD. 7 patients developed acute GVHD, among which 5 patients having both skin and gut GVHD, and 1 patient having only skin, and 1 patient having only grade 4 gut GVHD, which later led to mortality of that patient. 7 patients developed chronic GVHD, among them 3 patients having both skin and mouth GVHD, and 2 patients having severe skin, lungs, and grade 4 liver GVHD. Median follow-up of 27th month overall survival was 74%. Those patients who had transplant at younger age having better overall survival than those patients who have transplant at later age. Those patients who receive conditioning protocol of low ATG having better survival than of 82% than those patients who receive conditioning protocol of flu 150, Psi 30, and ATG 20. No statistically significant association was found between overall survival and ABO mismatch, gender mismatch, time since diagnosis, and source of stem cells. A patient who died among 3 of them were died due to primary graft failure, 2 are having GVHD, 1 died due to CMV pneumonia, and 1 died due to diffuse alveolar hemorrhage. A multi-center retrospective analysis by EMT in adolescents and adult patients showed an overall survival of 53%. This was a multi-center analysis, and they gave both flu-Psi ATG and also radiation-based conditioning to the patients. However, the patients in that study majority of them were age greater than 18 years, and their overall survival was 53%. Another study that was done in Turkey in pediatric patients showed an overall survival rate of 75% at 3 years follow-up. Our study demonstrated a survival advantage in Fanconi in patient of Fanconi anemia who were transplanted at younger age, and those who received a conditioning protocol of Psi 120, ATG 20, and fludarabine 120 as an acceptable conditioning protocol. And our study was comparable to the international data, as the study done in the Turkey was having overall survival rate of 70%, and our study, the survival rate was 74%. Thank you.
Right. Thank you, Dr. Mussawir, for enlightening us on data on Fanconi anemia and describing the radiation-free regimen, flu 120, Psi 30, and ATG 20 as an acceptable conditioning protocol for these patients. So I would just like to inform our virtual attendees that they can forward their questions on the virtual format, or they can send their direct questions to the number being displayed on the ticker below. Now moving on to our international guest speakers. Do we have Professor Craddock with us online? Do we? Yes? Okay. So our first speaker is Professor Charles Craddock. He is the Academic Director of the Center of Clinical Hematology, Queen Elizabeth Hospital, Birmingham, and Professor of Hemato-Oncology at the University of Birmingham. He has trained at the Hammersmith Hospital, London, the Institute of Molecular Medicine, University of Oxford, and the University of Washington, Seattle, USA. He is also a recent president of the British Society of Blood and Marrow Transplantation and the chair of UK Stem Cell Strategic Oversight Committee. His main research interests include development of novel drug and transplant therapies in myeloid leukemias. So he will be giving his talk on the allogeneic stem cell transplantation in AML, who, when, and how. So over to Professor Craddock.
Thank you very much indeed. Can you hear me okay?
Yes, you're quite audible, Professor.
Fantastic. And here are my slides. So first of all, I want to say thank you to this esteemed international hematology group, who it's a pleasure to be presenting new data to. And I remember with great fondness and affection my visits to Islamabad. I also want to congratulate you all on your recent fantastic victory against South Africa. And we're looking forward to future test matches. And for those of us who are following cricket in a more global context, it gives me great pleasure to inform you at the tea break on the first day in Chennai, England are 140 for 2, Sibley 53 not out, and Root, I think, on the way to another double century. So finally, I also want to just say what a privilege it is to be sharing a platform with a great mentor of mine and an absolute pioneer in stem cell transplantation, who's informed so much of our thinking and who's such a generous colleague, Andrea Bacigalupo. Good morning, Andrea. Perhaps his knowledge of cricket is less impressive than his knowledge of transplantation, but we can work on that. So I wanted to go through, in the time I have allowed, a little bit about the principles underlying stem cell transplantation in acute myeloid leukemia, and then talk a little bit about how we might be trying to improve outcomes in AML. I think the first important point to flag for this audience is that the allogeneic transplant procedure is unquestionably the most effective way of optimizing anti-leukemic therapy in acute myeloid leukemia. Now, what we have seen over the past 25 years really is two things. Firstly, a dramatic increase in stem cell donor availability through expansion of unrelated donors, expansion of cord blood, and more recently, expansion of haploidentical options. And the second thing has been a reduction in transplant-related mortality. This is partly because of better supportive care. Secondly, as Professor Bacigalupo has shown in a very elegant paper, because of a reduction in severe graft versus host disease over this period. And finally, because of the advent of reduced intensity transplants. So we're now in a position, if we have a suitable donor and a fit adult under the age of 65, that we can proceed to a transplant with a mortality that's predicted in the region of 15 to 20%. So the question then comes down to which patients should we transplant with AML? And I think the ELN consensus document drawn up by Jan Cornelissen about 7 or 8 years ago is really helpful in terms of informing our thinking. And let me just show you the pivotal data in this. And this is that the relapse risk, the hazard ratio for relapse in this HOVON study for adults with distinct cytogenetic subgroups of AML is consistently reduced. And the reduction is the hazard ratio is about 0.35. In other words, about a 65% reduction in relapse. This is more than halving the risk of relapse if you go to allograft compared with chemotherapy. And so we're really now in a position where we can actually start using a personalized prediction of relapse risk and also a personalized prediction of transplant-related mortality to decide how and who should go to transplant. So let me just go through that with you a little bit more. So the first thing is it's very important in choosing who we should take to transplant to understand what their relapse risk is if treated just with standard chemotherapy. And as you're aware, we're much better now at predicting relapse risk, and we can do that with molecular stratification. So it's clear not only that cytogenetics predict relapse risk and overall survival if treated with intensive chemotherapy, but also by introducing the results of next generation sequencing, particularly looking for mutations in genes such as CBP alpha, IDH2 or NPM1, we can identify relatively good risk patients with AML, but also by looking for genes such as ASXL1, TP53, and others, that you're able to identify patients with a very high risk of relapse if just treated with intensive chemo. The other methodology that is increasingly informative in terms of predicting relapse risk if treated with standard intensive chemotherapy is MRD stratification. And this on the left is some very nice work from my colleague Sylvie Freeman, showing that flow MRD after 2 courses can stratify patients in terms of relapse risk. And also on the right, the late David Grimway's work, showing that just looking in the peripheral blood at the number of NPM1 transcripts is a very good way of pulling out a population of patients with a low relapse risk. And then thinking about personalizing an allograft in terms of transplant-related mortality, we also know that the HCTI score, although somewhat imperfect, does allow us to pull out patients with a very low risk of TRM. It's important as we start to transplant older patients over 60, and this is some BSBMT data, to remember that older patients don't tolerate comorbidities very well. And this is a rather crude analysis, but if there's an HCTI score of more than 1, the transplant-related mortality in people over 60 can, depending on which the comorbidity is, really be very high. So how do we decide who to take to transplants? It's a decision many of us have in our clinic, either before we refer a patient for transplant or when we're sitting there looking at new referrals. And I think it's easy, actually. And this, again, I pay testament to Jan Cornelissen's clarity of thought on this. So the first thing to do in this dynamic risk assessment is to estimate in the patient sitting in front of you, what's the risk of disease relapse if we just treat that patient with chemotherapy alone? And then what's the risk of the patient dying of the transplant? So let's just take a population of patients who we would routinely not recommend transplanting. These are patients with favorable risk disease, either favorable cytogenetics or NPM1 positive with a good MRD response. So we predict that their relapse risk, if treated with chemotherapy alone, is probably in the region of, say, 35%. Well, if that patient is fit and has a good donor and their transplant-related mortality is around 15%, let's work it through. Well, we will see a reduction in relapse if those patients went to transplant, because I've told you that you more than halve the risk, so it would come down maybe to 15 to 20%. So for the patient, that would be a 20% benefit in terms of dying of relapse. But of course, if the chance of dying of the transplant's about 15%, then it's very difficult to make a persuasive case that the patient will substantially benefit, and they may well actually get significant toxicity. On the other hand, if you have a patient, let us say, who has a predicted risk of relapse if treated with chemotherapy alone of 50%, well, they go to transplant, there's a more than 50% reduction in relapse risk, so that comes down to, shall we say, 20. So that's a 30% benefit to the patient in terms of reduction of relapse and in terms of death from relapse. And if the transplant-related mortality is only 15%, well, that's a significant benefit from the transplant. And of course, as the predicted risk of relapse gets higher, and particularly in people over 50 or people with bad genetics, then the relapse risk can be about 70 or 80%, then the benefit incrementally mounts from transplant. So I think there's a general acceptance that if you predict that the relapse risk in a fit adult with an acceptable donor is more than 40%, one really should be thinking about about an allogeneic transplant, moving into a consultation with the patient, talking about toxicities, and on the whole, recommending these patients to go to transplant. And then I just now want to turn to having demonstrated to you that there has been a substantial reduction in the toxicity of transplant. What is the main reason for transplant still failing? And that, of course, is the risk of disease relapse, which can range between 30 and 70%. So let's just logically think in the remaining minutes about strategies that might be employed to reduce the risk of disease recurrence. Well, the first is, and we'll talk about this in a minute, there's evidence that patients who go into transplant, although they're in remission, if they have detectable, measurable residual disease by flow or molecular strategies, there's a high relapse risk. Well, maybe we could do something about that. Secondly, there's this enticing prospect that we could actually optimize the conditioning regimen so that it has powerful cytotoxic properties with reduced toxicity. And then finally, we know that there's a strong graft versus leukemia effect, and I'll show you the data after an allogeneic transplant. Maybe we could optimize that. So let's think through those strategies. Well, the first is, and this is data from our recent published Figaro study in JCO, that indeed pre-transplant measurable disease prospectively measured by flow prior to stem cell transplantation does indeed increase the risk of relapse. Interestingly, this is the only prospective analysis looking at flow determined MRD, and the impact of MRD is not quite as dramatically bad as numerous retrospective studies have shown. I think that makes 2 points. Firstly, you interpret retrospective translational data with great caution. And in fact, quite a lot of the retrospective studies on MRD and transplant that have been published are frankly misleading. And secondly, in fact, patients who go into a transplant with MRD, they still can actually have quite a good outcome. So we don't believe at the moment that if you've got detectable MRD, that should stop you proceeding to transplant. But nonetheless, there's an enticing prospect that if you did something about MRD, maybe transplant outcome would be better. Let me just now deal with the conditioning regimen. So there's a great question out there, given the fact that reduced intensity regimens are so well tolerated, should we all have reduced intensity regimens regardless of age? And there are 3 pivotal studies I'm going to briefly summarize. One was by the admirable German group led by Martin Bowenhäuser, the second by Nicholas Kroger looking in MDS, and then there's a US CTN study by Bart Scott. So this was the German study. 198 patients, took 5 years to recruit to this study, and they were randomized to what was called a MAC, which was Cy-TBI, or a RIC regimen, which interestingly was kind of right on the edge of a RIC because it had 8-grade TBI. And in essence, in this analysis and in a follow-up analysis, there was no improved survival in patients who had a MAC compared with a RIC. In other words, the RICs did just as well. So I haven't shown the Kroger data, which is just in MDS, and interestingly showed about the same. And then let's turn to the US CTN study. This was a larger study, 272 patients, and they had a MAC regimen, which was Bu-Cy or Cy-TBI, or they had a RIC regimen, which was either Flu-Bu-2 or Flu-Mel, and it was a very nicely performed study. And interestingly, in the RIC arm, there was reduced transplant-related mortality, less graft versus host disease, less chronic graft versus host disease, and equivalent overall survival. But interestingly, what you did observe in this study, and I refer you to figure A, the bottom curve, was an increased risk of relapse in the RIC cohort. Now, this study is widely quoted. And it's an admirable prospective study, but there are problems with this study. Firstly, because the relapse risk, yellow, in the RIC arm is much higher, almost 49%, than that is quoted in all other prospective data with RIC regimens. So that makes you sit up and think. And the other is that the relapse risk in the myeloablative arm, the blue arm, is dramatically smaller than, for example, the Rambaldi data that was published in Lancet Oncology with a similar regimen, where the relapse risk was 40%. Here it was about 19%. So this is interesting data, but I don't think it actually tells us whether patients should get a RIC or MAC. We've contributed in the UK to this debate in a paper recently published in JCO, where we wanted to look at whether intensification of a RIC arm using the sequential Flamza regimen was better than, again, the standard RIC arm of Flu-But2 or Flu-Melcampath. And this was a study where the primary outcome is 2-year overall survival. 244 patients randomized, recruited rapidly over 2.5 years. And although the Flamza regimen is widely used across Europe with no prospective data supporting it, what we find in this study is absolutely identical outcomes. A very similar TRM, similar overall survival, and no reduction in relapse. So our recommendation in our hospital around how we take patients to transplant at the moment is that if we can use a myeloablative regimen, that's broadly people under 55 who are fit, we use a myeloablative regimen in those patients. If patients are over 55 as a routine, we're using a RIC, and maybe if they're less fit and between 45 and higher, we're using a RIC regimen. And also, we don't believe there is any evidence that if you are in CR but have detectable MRD, you shouldn't go straight to transplant. So the Figaro study, it has informed our understanding about the impact of pre-transplant MRD, and it's also suggested the Flamza regimen may not be the way forward. So in the last 2 slides, I now want to discuss our current rapidly recruiting trials, one of which, the COSI study, really is largely attributable to Professor Bacigalupo, again, his genius. And this asks 3 randomizations. This takes high-risk AML, high-risk MDS, and there are a randomization before patients come to transplant, once they've had a donor identified. And many of these patients require a holding course of chemo. And we're asking a question here about, can you do anything about MRD? So those patients in randomization 1 of COSI get randomized either to experimental arm of CPX351 or intermediate dose 10 grams Ara-C. And then the other arm is looking at the regimen TBF that Professor Bacigalupo has pioneered, and in retrospective data looks so promising. And we're taking patients under the age of 55 and randomizing them Flu-Bu4 versus TBF, and in over 55 to FB2 or mini TBF. I'm pleased to report to Professor Bacigalupo this study is recruiting very rapidly. It's actually over-recruiting its targets. And in the last 2 months, despite the COVID lockdown, we randomized 25 patients. So we're going to finish this study earlier than we anticipated. And then finally, let me speak, and again, this is an idea generated by Professor Bacigalupo, evidence of a powerful graft versus leukemia effect. This is a UK study looking at patients who had a RIC allograft and showing that if they had high levels of exposure to cyclosporin post-transplant, you do blunt a graft versus leukemia effect. The relapse risk is high and the survival is low. In other words, there's a very potent graft versus leukemia effect after an allograft AML. Can we manipulate that? Well, the other piece of evidence to make us think that this may be important was additional data from the Figaro study, where we looked at the impact of acquisition of full donor T-cell chimerism on day 100 on outcome in patients who are MRD negative or MRD positive. Just look at the blue and the green curves. These are the blue and the red curves. These are patients who are MRD negative going into transplant. They do very well. Patients who are MRD positive, if they are mixed T-cell chimeras on day 100, the black curve, do very poorly with a very high rate of relapse. But if you are MRD positive and achieve 100% donor T-cell chimerism, you trump the adverse effect of pre-transplant MRD. So there's compelling data to say that if we can manipulate the GVL effect, that may be a benefit. And we believe that by using a therapy that manipulates the kinetics of relapse post-transplant, that prevents disease relapse, even delays disease relapse, may buy time for a graft versus leukemia effect and improve overall survival. There's clear evidence this may happen in patients transplanted for FLT3 positive AML who get post-transplant TKI, improved outcome with sorafenib in this lovely study from the US, and also we're waiting for the randomized post-transplant gilteritinib study. So what we're doing in the UK is a study called Amadeus, which is randomizing patients who've had an allograft for AML or high-risk MDS to 1 year's post-transplant oral azacitidine CC486. This study again is recruiting rapidly, and more than a third of the patients of the required 320 have been randomized. We anticipate closing that study out next year, and that will definitively look at whether azacitidine maintenance post-transplant is a benefit. So in conclusion, in the UK, our approach to understanding how to improve outcomes in AML is to deliver prospective randomized studies. I think it's a matter of great concern that there are so few prospective randomized studies in the field of transplant, and we're aiming in a small way to rectify that imbalance. And I've showed you how using the COSI and Amadeus, we're looking at new strategies to improve outcome. So it's been an absolute privilege to present some data to you, and I'm very happy to take any questions if there's time. Thank you very much.
Right. Thank you so much, Professor Craddock, for that really enlightening and fascinating talk on transplantation and AML. And I would also like to thank you for highlighting the role of T-cell chimerism in MRD positive AML patients. So we'll take the questions in the last. Now we'll move on to our next speaker, a name that requires no introduction in the field of bone marrow transplantation. That is Dr. Andrea Bacigalupo. He is the head of Department of Hematology at Hematology and Bone Marrow Transplantation Unit in Ospedale San Martino, Genova, Italy. He is also the president of a European Group of Bone Marrow Transplantation, that is EBMT, and member of the Scientific Advisory Board of Armenian Corporation. Dr. Bacigalupo's research interests lie in bone marrow transplantation, leukemia, graft versus leukemia effect, and aplastic anemia. His talk today will be on haploidentical bone marrow transplantation in aplastic anemia. If we have Dr. Bacigalupo, can you please connect to him?
Yes, I'm sharing my screen. Can you see it?
Yes, thank you. Good morning. I hope you're fine, doctor.
Can you see it now?
Yes, we can see your screen.
Lovely. So good morning. Good morning. It's a pleasure to be with you, although in a virtual state. And good morning, Charlie and Claudio and everybody, our friends. To share ideas in transplantation. So yes, the title is haploidentical transplants for aplastic anemia. We have recently looked at current published results in this area. And this is a very recent paper we have compiled on behalf of the European Group for Blood and Marrow Transplantation, looking at a systematic review and meta-analysis of clinical outcome of haploidentical transplants in these patients. This is what the study was about. We selected 16 studies, 15 for qualitative synthesis, and it compiled 577 patients, so a large number of patients. You can see engraftment is 97%, so very high rate of engraftment. 26% GVHD grade 2-4, not much. 25% chronic GVHD and 7% transplant mortality per year. The overall survival ranges between 70 and 95%. Please note that the median age is 17 years. So these studies are mainly in children or young adults, as you can see. So this has to be kept in mind. So yes, we have large number of patients, which means that transplanters are becoming familiar with the idea of using a haploidentical transplant in this population. But this is mainly in children and young adults. do we know which is the best platform? There are different platforms you can use to transplant these patients. This is a slide Sergio Kojima, the pediatrician in Nagoya, gave me. And as you can see, they use a combination of fludarabine and melphalan, 140 milligrams meter square, and 5 gray TBI. So this is a myeloablative regimen to engraft children with aplastic anemia and ATG, bone marrow transplant on day 0, and survival is excellent, as you can see, between 90 and 100%. But again, I'm talking about a myeloablative regimen. These are 2 centers, Ghassan and Shanghai, Nagoya. These again are children. And as you can see, the overall survival is extremely high, between 85 and 93%, with small numbers of patients experiencing primary graft failure, which is the problem in haploidentical transplants for aplastic anemia. Again, survival, you're looking at survival of 90%. So, of course, this could be extremely, extremely encouraging. Another study by a Korean group using alpha-beta T-cell depleted grafts. Again, a combination of fludarabine and radiation, 400 rads, and cyclophosphamide before transplant. And as I said, ex vivo T-cell depleted grafts. Again, incredible survival, 94%. So, you could say different platforms, excellent survival. Another platform, you see there's always radiation in these transplant platforms. In this case, 600 rads. So we're going up with radiation from the 200 rads of Rhinostor. We're going up to 600 rads, which is a significant amount of total body radiation, fludarabine, ATG, peripheral blood, and then a conventional tacrolimus. So this is a pretty sort of standard conditioning regimen, and one wonders whether this can only be done with this rate of success in Korean patients, or if it would be possible also in Western population. One wonders whether the HLA is more homogeneous in these populations. The age median was 47, so there are some adults, real adults here, as you can see, that survival is still quite encouraging. So yes, flu-mel, unmanipulated or flu-cy, alpha-beta T-cell depleted, a significant amount of radiation is given to these patients, and ATG is usually a fixed in the conditioning regimen. This is the program in China. It's a combination of fludarabine, cyclophosphamide, and ATG. And in China, as you know, they use a combination of G-mobilized bone marrow and G-mobilized peripheral blood. Basiliximab is given as a GVH prophylaxis together with cyclosporin and mycophenolate. This is the regimen, flu-cy, ATG 4 days. So this is 10 milligrams of ATG thymoglobulin, mesenchymal stem cells on day 0, and then a combination of G-mobilized bone marrow, G-mobilized peripheral blood, basiliximab on day 4, and cyclosporin mycophenolate. There is a significant amount, despite that GVH prophylaxis, there is a significant amount of grade 3-4 GVH. You see it's about 30%. 1 in 3 patients have grade 3-4 graft versus host disease, and chronic graft versus host disease is also in the order of 60%. Survival, 70% survival, with rejection and infections, and graft versus host disease, 12%. So children and young adults, you can use fludarabine, cyclophosphamide, ATG. You can use mesenchymal stem cells, bone marrow, and peripheral blood, the Chinese combination of progenitor cells. And again, in China, they use anti-CD25 cyclosporine mycophenolate. But as you can see, as you have seen, there is a significant graft-versus-host disease. This is the experience from Baltimore for non-malignant diseases. This is the first publication they have done in 2017. This is the conventional Baltimore regimen, as you can see, cyclophosphamide, 14.5 milligrams per kilo, 5 days of fludarabine, TBI, 2 grays, bone marrow, unmanipulated, cyclophosphamide, day 3-4, mycophenolate, tacrolimus, and G-CSF. And the Baltimore group has added the Canadian ATG regimen, 0.522 milligrams per kilo, but before the conditioning regimen. This is the new way of preparing patients with non-malignant diseases in Baltimore, giving ATG up front, not close to the transplant. In that publication, they had 16 patients and 16 were alive, so 100% survival. This is the more detailed conditioning regimen, so the 3 days of ATG, cyclophosphamide before the transplant and fludarabine, TBI, unmanipulated bone marrow, post-transplant cyclophosphamide, cyclosporine mycophenolate after. This is the update of the Baltimore experience. They have patients with a median age of 25, so between 3 and 69. So now we're talking about half of the patients being adults. They have 2 groups, relapse refractory, 22 patients having failed ATG, 22 patients alive. Incredible. 100% survival in failures. And then they have transplanted 17 patients up front. Instead of giving them ATG, they have transplanted these, and they have 15 alive. We'll show you what the problem has been. They had a problem with graft failure. So in the relapse remitting patients, they only had 1 in 20 patients rejecting, who was then salvaged with the second transplant. But in the naive patients, they had 3 graft rejections out of the first 7. So they increased the dose of TBI. Again, we're talking about radiation. And now they've done 10 patients naive, that's before any condition, any immunosuppressive therapy, and they have 0 rejection. So their program is to use 2 grays for the relapse remitting because they have already received ATG and immunosuppressive therapy, but they increased the dose to 400 in the naive patients, and this is a national US study now. It has been copied or confirmed by Carmen Bonfim, who's a transplanter, who's the transplanter in Curitiba, Brazil. They have done 87 haplotransplants for aplastic anemia, heavily transfused. All patients have failed immunosuppressive therapy. And as you can see, they have exactly copied the program in Baltimore with the ATG up front. They have done 2 changes. They have increased the cyclophosphamide before the transplant, you see, from 29 to 50, and they have also increased the radiation from 2 to 4 grays. Post-transplant cyclophosphamide, MMF, FK or cyclosporine, G-CSF, standard Baltimore regimen. This is the survival of 87 haplotransplants in Brazil. At many centers, so some also small centers, you may expect with a low experience in this type of transplant. And here you have the augmented Flu-Cy TBI. In other words, the patients who received the slightly increased dose of cyclophosphamide and the slightly increased dose of TBI did better, had less graft rejection, and had 90% survival. So the Baltimore protocol is excellent for haplo, and the results are confirmed in Curitiba. TBI 2 grays and cyclophosphamide 29 milligrams per kilo is probably a borderline effective regimen for patients with aplastic anemia. Possibly 400 rads and 50 milligrams is more effective in protecting patients against rejection. But then, of course, you will ask the question, what about fertility and second tumors? Because 400 rads begins to be a dose which may have an impact on fertility and second tumors. How do these results compare with HLA identical sibling transplants? I have only one slide, but I wanted to show you in this study, again by the Chinese colleague, 89 haplos and 69 SIBs, the haplos prepared with a Buci, a full dose Buci. So this is again myeloablative. And the siblings prepared with a Flu-Cy regimen, normal Flu-Cy. Please note the mortality, 6% in the haplo and 8% in the matched siblings. This is the median age, 22 and 33 years. And here is the survival curve. So in this publication, the Chinese colleagues are telling us that in their experience, the results of a haplotransplant given a myeloablative regimen and a sibling transplant have the same rate of survival at 3 years. So in conclusion, I think I've shown you that there are many different platforms in terms of conditioning regimen: Flu-Cy, Flu-Mel, Flu-Blue, Flu-Cy and TBI to 6 grays. The different GVH prophylaxis, ATG, cyclosporine mycophenolate basiliximab, or ATG, cyclosporine mycophenolate and post-transplant cyclophosphamide, the Baltimore approach. Who should we transplant with a haplo-identical donor? Well, I think certainly non-responders to immunosuppressive therapy are candidates, certainly children. Perhaps we should consider also adolescents and young adults. In adults over the age of 40, data are very early, and I would be a bit more cautious. And of course, if you don't have an appropriate unrelated matched donor or an appropriate cord blood with a high number of cells. Should we use these transplants up front? Today, I'm not sure. There's a protocol. I think also Professor Craddock just said that the best way to do it is a prospective study. And in the States, they are doing a prospective study of upfront haplo. We should perhaps wait tomorrow to have a definite opinion. And thank you very much for your attention.
Right. Thank you so much, Dr. Andrea, for your enlightening talk. It's quite comprehensive. It's one of the issues that we face frequently because aplastic anemia is quite high in incidence in Pakistan, and we are now looking at more and more haplo donors. So we have questions for you, but we are going to discuss them in the panel discussion in afterwards. So for our last talk of this session, we have Dr. Claudio Giardini. Dr. Giardini graduated to the Faculty of Medicine at University of Bologna in 1983. He did his specialization in general hematology from University of Parma and in oncology from University of Ancona in 1986 and 1989 respectively. He has been a part of the medical staff at the Division of Hematology and Bone Marrow Transplant Center of Pesaro since 1983. His main scientific interests include stem cell transplantation and follow-up of patients with malignant hemopathies and hemoglobinopathies like thalassemia and sickle cell anemia, post-transplant iron depletion, and therapy of hepatitis C, and the applications of stem cell transplantation with a matched unrelated donor in thalassemia major, which is going to be the topic of his talk. Dr. Claudio Giardini, please. Right. Hi. Good morning, Dr. Claudio.
Good morning of all of you. Ciao. Ciao, Andrea.
Oh.
It has been a pleasure to be here. I'm going to share with you a recorded intervention, and then I will be with you for discussion. Thanks. Dear colleagues, Thanks for inviting me at your Pakistan Society of Hematology annual meeting. I welcome all of you, all colleagues attending the meeting or hematologists present and attending at this session on bone marrow transplantation. The topic of this presentation is stem cell transplantation as a curative option for beta thalassemia. I'm going to share with you some data and concepts regarding this theme. With beta thalassemia, we define a hereditary anemia identified by reduced or absent production of the beta globin chains, which constitute the hemoglobin molecule. We don't want to go into details about the genetic of the disease, since several hundred mutations have been described in the beta globin encoding gene on chromosome 11. All these mutations lead at the same result, that is impossibility of mount the beta globin chain that constitute the adult hemoglobin molecule. This results in excess of alpha globin chains, formation of insoluble hemichromes in the erythrocyte precursors, ineffective erythropoiesis in the bone marrow, and severe hemolysis in the peripheral blood. In a severe anemia worsens a few months after birth, as soon as the fetal hemoglobin disappears, for the impossibility to substitute it with the adult type of hemoglobin. Since the genetic defect is expressed in the hematopoietic stem cells, it is rationally possible to eliminate the disorder marrow and substitute it with an allogenic marrow able to produce a normal hemoglobin. Allogenic stem cell transplantation is expected to prevent the disease progression, namely iron overload, transfusion-related complications and infections, and to improve the quality of life of the affected patients. When we consider allogenic stem cell transplantation for beta thalassemia, it is required that this therapeutic option is effective, that is a favorable safety profile, both looking at the short term and at the long term. These aspects have a great importance, since we compare transplantation with a non-malignant disease, potentially leading to a prolonged survival. Moreover, the option of transplant must be feasible. And this means, for example, the availability of stem cell donors to each transplant candidate. And we will go soon at the details regarding this aspect. Finally, the option of transplant must be available, and this involves, for example, the existence of hospitals with the transplant units in those countries where the disease is diffused. These transplant units must grow with dedicated physician teams, with adequate financial support, and must have clinical programs either for autologous transplants and allogenic transplants for leukemia, lymphoma, aplastic anemia, and hemoglobinopathies. However, the first argument to consider allogenic stem cell transplantation in hemoglobinopathies is the possibility of a definitive cure of the disease compared with the best management of symptoms and complications with a transfusion and chelation therapy approach. Allogenic stem cell transplantation is the only established curative therapy for hemoglobinopathies with almost 40 years of clinical experience, and it has been currently applied to several thousands of patients worldwide. However, caution is needed in considering this option for a non-malignant hematologic disease. The possibility of cure, but also the expected transplant-related complications, graft versus host disease, and the transplant-related mortality must be balanced with a disease that permits today a prolonged survival when transfusions and chelation therapy are applied at an optimal level. Patients with beta thalassemia have a reduced possibility of survival compared with the general population. However, this probability of survival has increased in the last decades due to the application of modern protocols of management of the disease. This Kaplan-Meier curve on the right shows exactly this concept. Patients born from 1960 to 1964 have a 50% possibility of dying from disease complications by the age of 20 years. Patients born in more recent years have a survival rate that is remarkably higher. However, this last curve shows the probability of survival in a population of thalassemia patients living in a developing country like Iran, and it shows that the life expectancy for this population of patients is still short. Remarkably, beta thalassemia is a disease diffused in countries where the optimal care of a chronic transfusion and chelation therapy is not often available and has an enormous financial cost for the healthcare system and for families. This is the first transplant in thalassemia reported in the scientific literature dated 1982 by Dan Thomas from the Fred Hutchinson Cancer Research Center in Seattle in a non-transfused 16-month-old child. After this case report, the group of Pesaro, Italy, started since then an extensive work in this field with more than 1,100 transplants in beta thalassemia performed from 1982 to the first years of the 21st century. This is probably a well-known statistical analysis done in 1989 by the group of Pesaro. The result of this analysis lead us to identify patients with the best chances of success, patients in class 1, patients at an intermediate risk, class 2, and patients at high risk for the transplant approach, class 3, on the basis of these 3 risk factors: hepatomegaly, a history of irregular chelation performed before transplant, and presence of liver fibrosis at the pre-transplant liver biopsy. It is an obvious observation that the 3 classes of risk for the transplant coming from this statistical analysis reflect the distinction between fit and unfit patients. Patients who are classified in class 1 are of younger age, received a low number of transfusions, have a low ferritin level, and no cardiac or liver dysfunction. On the contrary, patients who are classified in class 3 are patients with already established organ damage, older age, and this organ damage is related to cardiac, liver, and organ iron accumulation. This slide shows the overall survival and disease-free survival for thalassemia patients divided in classes of risk. Very good results in patients in class 1 with a reported survival rate and disease-free survival of 94%. Around 80% survival for patients classified in class 2. For class 3, the initially reported outcome was very poor, with a transplant-related mortality of 39% and a disease-free survival of only 53%. The aim of the following clinical research has been to improve the survival after transplantation for this high-risk category using a less toxic and intensive conditioning regimen. These are the major steps reported in literature by the Pesaro group, with the most recent data showing more than 80% disease-free survival. For adult patients, results reported are survival 65% and disease-free survival 62%. This is a conditioning regimen for class 3 thalassemic patients proposed in 1997 by the Pesaro group, with immunomodulation with azathioprine and fludarabine, and cytoreduction using hypertransfusion and hydroxyurea during a preconditioning phase, and using busulfan and a reduced dose of cyclophosphamide as conditioning regimen. This is a more recent proposed protocol dated 2016 with the addition of thiotepa to the previously reported preparation. And in this table, you see several proposed conditioning regimen recently reported in literature for high-risk patients. Some of these studies reported the use of treosulfan instead of intravenous busulfan, with encouraging results in terms of toxicity, survival, and incidence of graft-versus-host disease. Other studies reported the need of a busulfan dose adjustment on the basis of the drug blood level. This is a report of the European Society for Blood and Marrow Transplantation, analyzing data from 1,493 patients. Results are very good in young patients with a 2 years survival rate of 94% and a disease-free survival of 86%, and in patients transplanted with a matched sibling donor or a matched unrelated donor. Less optimistic results for transplant from non-HLA identical donors. Very similar results are reported in this series of 1,110 patients transplanted in China, India, and coming from the International Bone Marrow Transplant Registry in Milwaukee. At present, we can consider as marrow donors an HLA identical sibling that is available in about 25% of cases. That remains the best donor we can use. But also we can search for a matched unrelated donor with the similar results when a full match unrelated donor is found in the registry. We can also search for a cord blood unit. And finally, we can consider an HLA haploidentical family donor. That means a donor who shares only 50% of the HLA antigens with our patient. This last possibility has been explored more recently due to new protocols already in use for transplants in malignancies. Almost 95% of potential transplant candidates has a suitable haploidentical donor in the family. So the pool of potential marrow or stem cell donors has expanded markedly, making the transplant feasible in the vast majority of transplant candidates. These are the two major platforms used for haploidentical transplant. Post-transplant high doses of cyclophosphamide or in vitro depletion of selected subpopulation of T lymphocytes. The use of high doses of cyclophosphamide on days 3 and 4 post-transplant has been originally proposed by the group of Baltimore in haploidentical transplants for leukemia and lymphoma. The drug selectively kills alloreactive T cells but do not damage CD34 positive stem cells, producing an efficient immunosuppression without compromising the post-transplant engraftment. This small casuistic show the results of haploidentical transplant using an in vitro T depletion. 11 patients transplanted, 9 out of 11 who show engraftment and overall survival of 84% and disease-free survival of 69%. The results of the platform with the post-transplant high doses of cyclophosphamide, 31 cases reported by this colleague working in Thailand with a disease-free survival of 94%, so very good and promising results. This is the details of the protocol. Acute and chronic graft-versus-host disease, very limited. Number of transplant for non-malignant hematologic disorders reported at the EBMT registry has increased over time. You can see here the number of transplants done during the years for bone marrow failure, for hemoglobinopathies, this curve in green, for primary immunodeficiency, for inherited order or error of metabolism, and for autoimmune disease. Obviously, this curve take together hemoglobinopathies, that means a transplant for beta thalassemia and sickle cell disease. Also, the number of transplants from haploidentical donors, this curve in yellow, has been the biggest increase over time, thanks to the described new platforms. Long-term outcome and late effects. This study report late effects in a cohort of 99 patients transplanted in France and followed for 7 to 20 years after transplant. They observed the appearance of thyroid dysfunction in 11% of patients, diabetes in 5% hypogonadism, mainly in female patients. 40% of female patients show a preserved fertility. Also, we must remember chronic graft-versus-host disease that, when present, can severely impair the quality of life of the affected patients. Fortunately, it happens in a very low percentage. And also we must remember the possibility of secondary tumors, mainly skin cancer, that have also been reported, particularly in patients with chronic graft-versus-host disease, but also individual case report of liver cancers in patients transplanted in a pre-cirrhotic state due to iron overload and hepatitis C. On the other hand, these pictures show here the pre-transplant liver biopsy of a class 3 thalassemic patient showing extensive fibrotic damage and very heavy iron deposit. These pictures here show the liver biopsy of the same patient years after transplant, after an intensive iron depletion therapy. In this situation, we describe that the transplant permits a complete healing of the damaged organ. What we can conclude about allogenic stem cell transplantation for beta thalassemia? Just outline some concepts. We have a very good outcome with more than 85% disease-free survival when we use a match-related or unrelated donor. Results are even more favorable when we transplant patients in very young age. We must consider also that hematopoietic stem cell transplantation is cost-effective compared with a lifelong management with transfusion and chelation. It's also important to outline that it's very important to finance and support specialized stem cell transplant units that are crucial for a comprehensive healthcare system in each country. We must remember problems correlated with the transplant procedure, the late toxicity that is related to the conditioning regimen and the drugs used for conditioning the transplant, and graft-versus-host disease that remains a problem, but also in this field results improve. Finally, we must outline that transplant from haploidentical donors are steadily improving and give very promising results. However, we cannot say that this approach is a standard care for thalassemia, but we still need to consider this like clinical research. Let me finish with a brief excursion to a new curative approach for beta thalassemia, that is gene therapy. For gene therapy, we mean autologous stem cell transplantation with ex vivo insertion of the damaged gene. And this is the treatment plan. First, we need mobilization and harvesting of CD34 positive stem cells. Then we need to manipulate these stem cells with the insertion of the gene encoding for beta globin chain production. We need a myeloablation of the thalassemic marrow, and then the reinfusion of modified CD34 autologous stem cells into the patient. several clinical trials of gene therapy for thalassemia are underway. One of them at the San Raffaele Institute of Gene Therapy in Milan, with very promising preliminary results, possibly leading this option the future for cure of beta thalassemia. Thanks a lot for your attention, dear colleagues.
Right. Thank you so much, Dr. Claudio, for your really enlightening talk on thalassemia. As you would have seen in one of the free paper presentations, that aplastic anemia and thalassemia are the major indications of transplant in our country. So I would like to have all our panelists with us, if we can have all of them. From Karachi, we have Dr. Tahir Shamsi, a name that does not require any introduction for hematologists in Pakistan. Good afternoon, sir. Assalamu alaikum. Kaise hain aap?
Walaikum assalam. I'm fine, thank you.
And also joining us from Karachi is Dr. Salman Adil, hematologist and senior transplant specialist working with Aga Khan University Hospital. Sir, assalamu alaikum to you as well.
Alaikum, good morning, good afternoon,
Good
in
afternoon.
fact,
Good afternoon.
for our international colleagues.
Sir. And here with us in hall we have Dr. Qamar Nisa Chaudhary, also a senior hematologist and transplant specialist. She is the head of AFBMTC and IBMT, Rawalpindi. Ma'am, good afternoon. Assalamu alaikum to you as well.
Yes, good afternoon.
So we would like to start with the questions that we've got from our virtual attendees, and it's good that you are all participating. So we'll proceed with the questions in the sequence of presentations of our speakers. So we have questions for Professor Charles Craddock. This is by Dr. Rahil Iftikhar. He wants to know which MRD markers would you consider for treatment decisions, like which molecular markers do you think are more suitable to monitor?
Thank you. I think it's a very good question indeed. And I think the first question, of course, is the extent to which MRD changes treatment management. Now, I think it is important in particular subgroups in terms of definitively changing your treatment before you proceed to a transplant. And I think that is notably the case in NPM1 positive AML, where there's an RQ-PCR strategy which is highly reproducible. And we know that patients with NPM1 positive AML who have detectable NPM1 transcripts in the peripheral blood after 2 courses of induction chemo should go to transplant, but otherwise they should be treated with chemo. Now, I think MRD is of value beyond that pre-transplant in risk stratification. And in most settings, we're predominantly using flow cytometry, looking for leukemic-associated progenitors, and looking with a threshold of between 0.1 and 0.2. But in all honesty, I think the number of patients over 40 in which flow-based MRD after 2 courses of intensive chemo pushes patients away from transplant or into transplant is quite small. But nonetheless, I think if one has the resource, that would be the way I'd go. I think NGS is exciting, it's expensive, and it's still experimental. I think the other area where MRD is really important in the context of transplant is monitoring patients with detectable leukemia-specific transcripts. Again, NPM1, but also some of the MLL rearrangements, KMT2A. So we routinely monitor patients transplanted for NPM1, CBF alpha, CBF abnormalities, or MLL rearrangement by qPCR strategies 3 monthly for 2 years post-transplant, because patients who become molecularly positive have a very good response to DLI.
Right, thank you. So there is another question for you, Professor Craddock, and that's from one of our attendees in Karachi. This is from Dr. Irfan Ahmed of Liaquat National Hospital. He wants to know, is BMT in AML exclusively indicated in high-risk groups only, across all groups based on MRD after the second cycles?
Yeah, so it's a really good question, and I think it actually it depends what you call high risk AML, doesn't it? And in fact, many of us would say that, you know, the term that is used, good risk cytogenetics, if you actually look at the outcome of people with 821 over the age of 40, it isn't actually that good. So what I would say is that the Cornelison ELN Concordat about a dynamic decision-making process according predicted risk of relapse if treated with chemotherapy alone and predicted transplant-related mortality is the way to go. And I think we should drop the term high-risk AML. I don't think it's particularly helpful. And I think what I was saying in that talk was that if your predicted risk of relapse is more than 40% on the basis of cytogenetics, NGS, or the MRD strategies I've spoken to, then one should consider stem cell transplantation. I thought that Claudio's talk, you know, was really thoughtful, because the other thing one wants to take into account with the family is the toxicity, the long-term toxicity of transplant. And there may be patients who fall into this group with a higher predicted risk of relapse who don't want to go to transplant for reasons of fertility, or particularly in perhaps slightly older patients who have a caring responsibility. They don't want to take on the risk of chronic GVHD. But we would be using, I don't know what Andrea says, but you know, a cutoff of around a predicted risk of relapse of more than 40% as potential candidates for transplant.
Right. I hope that answers your question, Dr. Fan. So the next question is for Dr. Bacigalupo, and it's also from Dr. Rahil Iftikhar. He says that for CMV, we have ganciclovir and valganciclovir. And the data in our country shows that almost 80% of the patients who undergo a haploidentical transplant have CMV reactivation. So do you think, do you have any data that suggests the use of pre-transplant or pre-engraftment usage of, you know, for prophylaxis of CMV?
Thank you very much for the question. Now that we have letermovir, of course, if we use prophylaxis of CMV, at least in our experience, it seems that the problem of CMV, if not disappeared, is almost disappeared. It was interesting that yesterday we had another call with international colleagues, and in Baltimore, the use of letermovir is not standard, for example, whereas in some centers, the use of prophylaxis has become standard. Certainly for alternative donor transplants, and especially haplo mismatch transplants. Whether this will reduce mortality in the haplo setting is a bit more difficult to assess. In other words, yes, preemptive therapy with ganciclovir or foscarnet or valganciclovir is extremely effective, so that you can still prevent CMV disease. The question you're asking is whether we should use prophylaxis. And I think that depends on logistics, local protocols, and the impact of CMV in your patient population.
All right, thank you. And what exactly
Can I
sure,
comment
please.
on this
Sir,
particular
please.
question? Yeah, I think our population is seropositive, even young children, 2 years of age, who are coming for transplant, both donor-recipient pair, they show seropositivity of CMV. Almost, I would say, 99% of our patient cohort are CMV positive. So certainly what we see is reactivation of CMV. And in the haplo transplant setting, those who receive ATG-based conditioning, they tend to have more CMV reactivation. And again, if you using slightly lower doses, 2 milligram or maybe lesser than 2 milligram, that as compared to using 3 milligram of ATG, the higher the dose, the higher the chances of reactivation. And the protocols, certain protocols, if you're using those, excluding ATG, good, focusing more on post-transplant cyclo. So you tend to have lesser CMV reactivation. So this is our experience during last 6-7 years of doing haploidentical for hematological disorders.
I agree.
Right, and is there a particular dose in which it should be used for these patients? If we use them for, prophylaxis, pre-engraftment?
You're talking about ATG or
CMV, for CMV?
ATG?
No, I'm talking about...
No, I think he's asking about the prophylaxis for CMV using ganciclovir or foscarnet.
Right. So, we have been using foscarnet low dose, 60 milligrams, between 40 and 60 milligrams per kilo in alternative donor transplants in the early first decade of this century. And we had good results, but you have to keep your patients in your daycare unit 5 days a week because it's intravenous. Yeah. So it's a bit cumbersome, but it can be done, and it clearly is effective in preventing. Of course, current ganciclovir produces cytopenia, so we do not use it for CMV prophylaxis. We use the termovir for CMV prophylaxis.
Right. Thank you. So we have another question for you, Dr. Andrea. It's from Dr. Parvez Ahmed, and he wants to know your experience of haplo and Fanconi anemia. Have you done haplo and Fanconi?
No, I have not done haplo and Fanconi anemia. I know that Franco Locatelli here in Rome at Bambin Gesù has a very active program with alpha beta T cell depletion in Fanconi anemia and other non-malignant disorders. His results are fantastic. In other words, he has no graft versus host disease and close to 100% survival. So the answer is with an ex vivo T cell depletion, at least as Franco Locatelli does it, results seem to be extremely good because Fanconi anemia has problems with graft versus host disease, has problems with methotrexate. So alpha beta T cell depletion in that condition seems to be quite indicated.
All right, thank you. So Dr. Claudio, we have a question for you as well from Dr. Parvez, and he wants to know the effect of is there effect of degree of hepatic fibrosis in class 3 in patients who are in class 3 and your experience for haplo and thalassemia, the effect of hepatic fibrosis?
No, liver fibrosis is a situation that can affect the post-transplant outcome. I mean that it can go to a progression if there is still an activity of the hepatitis C virus post-transplant, and if the heavy iron overload is not removed with a post-transplant phlebotomy program or chelation therapy. For this reason, liver fibrosis is an important situation that must be followed during years after transplant. As you have seen with antiviral therapy for hepatitis C and with an appropriate iron depletion, we can hope for a restoration of the liver situation to a normal level. The percentage of fibrosis is not itself a prognostic factor for the transplant outcome, excluding situation in which the liver show cirrhotic damage. In this situation, we can expect more toxicity and transplant-related mortality due to this heavy organ damage.
Thank you. So there's another question for you. This is from Professor Wasim Iqbal from Karachi. And he wants to know what is the exclusion criteria for not doing stem cell transplant in patients of beta thalassemia?
One can be established liver cirrhosis that is expected to give a high mortality. And the other one is an echocardiography that show a very important impairment of the cardiac pump function.
Right. I hope that answers the question. We have two more questions for you, Professor Craddock. And one is from Dr. Nigat Shahbaz. I believe she has worked with you as well. And she wants to know that in patients of AML, we are mainly relying on early tapering of CSA and T-cell chimerism. What's your experience? Do you agree, or should we do something else with it as well?
So it's a real privilege to say hello to Nigat, my wonderful colleague who worked with us for so long. And also I'd like to say a shout out, please, to Pervez, who ran the Rawalpindi transplant program so brilliantly and is a great friend as well. Hi, Nigat. So my view on this is firstly that the dosing and levels of cyclosporin that are administered post-transplant are dependent on the conditioning regimen, donor type, and the use of T-cell depletion. And as a unit, one needs to come together and have a consensus as to what should be the levels that you are aiming to achieve. And also really critically, and this is often ignored, the timing and pace of a cyclosporin taper. But I think in complex medical interventions such as transplant, you get great results by doing simple things well. And one of the simple things that can quite often be ignored is indeed, as you infer, measuring cyclosporin levels 3 times a week and adjusting the levels according to an agreed consensus. You've seen from our data and from Professor Bacigalupo's data that the impact on disease relapse, if you have high cyclosporin levels, is really significant. There's an increased risk of 30 or 40%. So it's of pivotal importance that you get cyclosporin right. I think there's also a big question, it's a simple question for the literature, for the field, as to when should we taper and how should we taper. And one of the simplest trials I'd like to do is a randomized study of rapid versus late taper. With regard to T-cell chimerism, I think it's somewhat more contentious. My sense is that in a myeloablative transplant, chimerism studies for in leukemia don't add very much. But in reduced intensity transplants, particularly where you've used ATG or Campath, we believe that acquisition of full donor T-cell chimerism by DLI is of benefit. We haven't got randomized data, but I'm pleased to say that the IMPACT Pro-DLI study has closed ahead of schedule, the first randomized study ever of DLI post-transplant patients allografted for AML, and we hope to be informed by those data. So nonetheless, our routine practice, Nigat, would be as if you have mixed T-cell chimerism, off immunosuppression, you have no history of GVHD, and you don't have big mismatch, that we would cautiously use prophylactic DLI, aiming to achieve full donor T-cell chimerism. But I think those data that must be informed by the results of the Pro-DLI trial.
All right, thank you. So there is another question for you, Professor Craddock, and this is from Dr. Ghulam Nabi Kakipoto from New Cross, UK. And he wants to know, in this current scenario of COVID, what would you recommend holding the disease like high-grade MDS or AML with use of azacitidine? And if possible, for how long can we hold it?
Yeah, so, I mean, it's a very topical question, and there are different views. My view, I think the next major advance in the treatment of fit adult AML, I'm convinced, but we need randomized data, is that venetoclax-azacitidine combinations are going to increasingly be used instead of intensive chemotherapy to get people to transplant. And I think they actually might be quite interested as a bridge to transplant. So our strategy, because in the UK we can access venetoclax and azacitidine, would be to utilize Ven-Aza as opposed to intensive chemotherapy, certainly in patients over 50 and certainly in patients with an NPM1 abnormality. So we would be doing what you've said, but actually switching more towards a Ven-Aza combo. If you can't get hold of the Ven, I'd prefer to use Aza. We are trying not just for the next few weeks to bring patients in for an allograft, because as you know, in common with Spain and Italy and France, the pandemic is really complicating our ability to safely deliver transplant. But I hope in 2 or 3 months we'll be out of this thanks to vaccination.
So just a brief question here. So we've been using venetoclax and decitabine and azacitidine as well in some patients. And what we've seen in AML is that the bone marrow, after these treatments, 2 or 3 cycles, then you have extreme fibrosis and increased megakaryocytes. So have you had the chance of seeing that in your patients?
We don't see that so much. I mean, I think it may depend on what the original diagnosis was, because sometimes patients are put back to a sort of pre-MDS or a pre-MPD state, aren't they? The challenge, I think, with venetoclax, which I'm sure you've overcome, is the problem with cytopenia and when you assess response. So we're assessing response routinely on day 28. And then in people with neutropenia, as long as they've in CR, we give them at least a 14 days delay before starting the Ven-Aza. And we sometimes actually abbreviate the subsequent dose of Aza. But we haven't seen this problem. Maybe we will see more of it. I know that the MD Anderson, Courtney Donato, is always very happy to receive questions, and you might drop her a note. I think she gives you some very helpful information.
Right. So there's another question for Dr. Giardini from Dr. Nigat Shabazz, and she wants to know if we can reduce the risk of graft rejection by increasing the dose of BU from 14 to 16. What are your comments on that?
Sorry, was this for Andrea or me?
That's for Dr. Claudio Giardini.
Oh, sorry, Dr.
In thalassemia, sorry. So I should have mentioned it's for thalassemia.
That's a relief.
In our experience, we don't want to increase the dose of busulfan. The very early clinical protocols were using 16 milligrams of busulfan, and they were abandoned for higher toxicity. So I would like to increase the dose of busulfan over that proposed.
Andrea, could you please also add something to it?
Regarding the dose of busulfan?
Yeah, regarding the dose of busulfan, yes, because that's a controversial subject that we're discussing nowadays.
Yeah, as I have shown in the presentation, there are some colleagues that suggest busulfan blood level check and tailor the dose of busulfan according to the blood level, just to be sure that we are on the therapeutic level. But this is also controversial. Some other author was exploring a possible best profile of triosulfan instead of intravenous busulfan. In the experience of the hematology unit in Pesaro, we ever use intravenous busulfan, not triosulfan. And when we need to intensify the conditioning regimen. This was done with the pre-conditioning regimen, immunosuppression and cytoreduction with the use of fludarabine before the conditioning regimen. And lastly, with the add of tiotepa in the middle from biosulfan to cytoxan.
All right, we have another question from Dr. Mansoor Beg. It's from UK, and he wants to ask Professor Craddock that what are the options for an 83-year-old patient who has MDS, is a non-transplant candidate, non-intensive chemo candidate, and he has progressed to AML on the second cycle of 5-AZA. So what options does he have to offer to that patient?
Well, I think this is a very difficult clinical situation, isn't it? I think if you had access to venetoclax, but actually in the UK and in large parts of Europe, we still don't, then the VIALE-C study included this population of patients, and actually with longer follow-up, there's a survival benefit of a ven-Ara-C-based regimen. So I think if you could access venetoclax, but I'm afraid to say our practice is that in patients who are azacitidine failures, who aren't transplant candidates, given the very, very poor overall survival of this group, it's about 4 months. And in the absence of an actionable mutation, we wouldn't have any therapeutic intervention. Clearly, if the patient had a P53 mutation and you had a P53 study with something like CD47, magrolimab, that would be interesting. But we have quite a lot of these patients, and I'm afraid we don't have anything useful to offer. I'm sorry. I hope the future will change.
Can I just add to, or maybe a comment from Dr. Craddock? We have access, fortunately, of venetoclax in Pakistan, and we are using an azacitidine venetoclax combination in number of patients. In a few patients, can you just comment on it? What has happened is that they have initially shown a response, but the marrow become completely aplastic after 2 or 3 cycles, and but they still have blast cells in the peripheral blood. This has happened at least to 2 patients who have recently received the azacitidine venetoclax combination.
Yeah, so this is a discrepancy then between the peripheral blood and the bone marrow, is that right?
That's right, yeah.
Right. That is certainly unusual. There is a significant risk of incidence of resistance to ven-aza combinations. So again, I'd want to really scrutinize as to whether the patient had resistant disease. But if they've had a convincing marrow response, I'd probably be inclined to ignore the circulating blasts, give them time away from the ven. You often have to give 2, 3, 4 weeks. I think GCSF has found to be particularly useful in these populations with aplastic marrows. And then I'd want to re-challenge them with a ven-aza combo.
Right. There is another question from Dr. Rabia Ahmed from Lahore for Dr. Claudio Giardini, and she wants to know is there an indication of transplanting a well-chelated thalassaemic patient?
Sorry, can you repeat?
Yeah. The question is that the doctor wants to find out, is there any indication of transplanting a well-chelated thalassemia patient?
The answer is yes. The bone marrow transplantation as the only curative option for beta thalassemia. We must remember this situation. When we have a patient in a very good clinical condition, well chelated, well transfused, you can not be sure that this will be the situation for the next and prolonged future, because there are a lot of problems that can happen during the situation, the clinical situation, lifelong. I mean, alloimmunization for red cell antigens that can create an hemolysis and the difficulty of transfusion therapy, an increase of the necessity of red blood cell transfusion, and consequently the difficulties to maintain an optimal level of iron chelation when transfusions are increased in time. So we have done transplants in thalassemia in Italy, where there is a good healthcare system that make transfusions and chelation free of cost for the families. And our clinical experience come from this situation, developed country with a good possibility of survival for non-transplanted patient with a well-done transfusion and chelation therapy. We think that in a developing country there is an argument more in favor of stem cell transplantation, because the life expectancies in this situation is sometimes shortly.
Claudio, can I ask you a question? Do you do anything about the gonadal function, preservation of the gonadal function for girls undergoing transplant very early in life, of course, for beta thalassemia major? That's for Claudio.
Yes, I think it's important to propose before transplant for pre-transplant candidates the oocyte or sperm cryopreservation.
Do you actually do that? I mean, at your center, have you been doing that in routine practice?
We propose to every patient before transplant to do that. Yeah.
Okay, thank you.
Right. So there's one last question from Dr. Waqas Bukhari from Lahore, and he wants to ask Professor Craddock his experience of patients with AML, and if the donor is a match unrelated donor versus a haploidentical sibling. So what's your data or experience on that, Professor?
Well, I think this is clearly an area of really, exciting promise. And I think, I think Professor Bacigalupo will add light to this. My take on this is that haploidentical transplantation offers a really important stem cell source option for many patients who don't have such an option. I think that's very encouraging. It's maturing data now. I don't think that we really have compelling prospective data. So the position we have in the UK broadly is that where we have an opportunity of using a 10 out of 10 or a 9 out of 10 donor in this setting, we would utilize that as a donor, but we would be considering cord blood because we can access that free, or a haplo in patients who don't have such a donor. My caveat about haploidentical transplantation is I think there are a bewildering array of strategies for GVHD prophylaxis, and I'm still unclear what the optimal way of delivering it. But I think that, the work of Andrea and colleagues is defining a very important role. Finally, I think we need to move away from, cord good, haplo good, or unrelated good. I think it's going to be much more nuanced. It's going to depend on patient disease and stem cell characteristics. So there's no doubt that there are going to be patients I'm clear about in which haplo may be preferred, cord may be preferred, or an adult unrelated. I think we need accumulating prospective data.
Right. And your comments on this, Dr. Bacigalupo, mud versus sibling haploidentical? Can you hear us, Dr. Andrea?
Sorry, I replied. What was the question?
So we want to know your experience on AML, if the donor is a match unrelated donor versus a haploidentical sibling.
Good question. It depends on your GVH prophylaxis. We have been doing lots of haplos in AML. We're now doing lots of matched unrelated because you get less GVH if you use the same GVH prophylaxis. So it's a very good question, and I think there's a European randomized study going back to what Professor Craddock was saying, we should do it prospectively. There's a randomized trial which will compare haplos and MUDs with the same GVH prophylaxis, which we have never done. And then we will know whether we will get less graft versus host disease in the unrelated matched, which is what we expect.
I completely agree.
Right. Thank you so much for being with us, our esteemed international speakers and our local heroes in hematology from Pakistan as well. So we did have a session of 3 free papers to start our bone marrow transplant session. And if the panelists have any questions to our young hematology residents regarding their papers, and if not, then we can close the session.
In fact, those presentations cannot be undermined in the presence of the esteemed international audience. But those poor chaps had little time and they had to run through it. So, but Dr. Ayesha Iftikhar presented her data on acute GVAD after stem cell transplantation, though it was on acute GVAD. But I was just wondering whether she would share any experience of using ruxolitinib in chronic GVAD in those patients.
Dr. Ayesha, would you like to answer the role of Jakafi or ruxolitinib in acute GVHD? Have you have any experience of using it with your patients?
So yes, we have recently started using Jakafi in few of our patients, but since my study did not actually, we did not see the result of Jakafi and we did not really go through it, so I cannot tell you the exact percentage, but yes, recently we have been using Jakafi in few of our patients.
And have you, if you're not analyzed it, but what kind of response do you see? Do you think it's good?
It has been a good response in the patient that we have started using recently. And hopefully after a few years, probably we can present the data of our patients who have been using Jakafi and their outcomes in the QGVAD.
Right. Dr. Qamar, would you like to add something to it?
Oh, yes. So we've been using Jakafi. I mean, several of our patients, children as well as adults, have received Jakafi both for extensive skin GVHD, chronic GVHD, and we've had excellent responses. We've had very good responses in patients who had extensive GVHD, not only of the skin but as well as of the gut. So I think quite good data, in fact, and I think we will be able to present that in another conference sometime, yeah.
Right. Thank you so much. Thank you to all our speakers, to our residents, and to all those attendees who joined us in this hall as well as virtually. And on behalf of President PESH, Dr. Parvez Ahmed, I would like to thank Professor Charles Craddock, Dr. Andrea Bacigalupo, and Dr. Claudio Giardini, along with our panelists, Dr. Tahir Shamsi, Dr. Salman Adil, and Dr. Qamar Nisa. Thank you so much for joining us and enlightening us regarding stem cell transplantation. Thank you, and have a good day.